Are they already in Chicago?
The one and only Leo Biaz. Hey, Leo.
I'm excited to be back, my man. It was 9 days in Vegas. We got stuck in the desert, and we had a little hangover remix out there, man.
I wore a wig to school once, and they said no headgear was allowed.
How did the
spider web
was it
tights.
Obvious that it was a wig?
Yeah.
Oh, okay.
I was
It was
having
a terrible
fun.
wig.
See, this is exactly why we have them on the show, and this is what makes them fun.
You're listening to KXVS, the voice of Stockton, 92.1 FM.
KXVS on 92.1. Coming soon.
This is Darius Oliver, and you're listening to 92.1 KXVS, the voice of Stockton.
And welcome to Connections Radio. Here's your host, Bruce Judici.
Good evening. This is Peace and Justice Connections, and what we're going to be talking about this evening is single-payer healthcare. And tonight we have Kathy Mathis and Max Heineman with us from Single Payer Health, and I can introduce our guests this evening. Kathy is the co-chair. Kathy Mathis is the co-chair of Single Payer San Joaquin, which is our local single payer advocacy group, founded in the early aughts, which is around 2003. And she's a practicing physician here in Stockton, and also serves on the board of directors for the Peace and Justice Network, which sponsors this program, and the San Joaquin Audubon Society. And in addition, she holds elective office as the trustee from the Manteca, Escalon, Lathrop area of the San Joaquin Delta Community College District. So, what do you do in your spare time, Kathy? And that's Kathy. And Max has a Master's of Social Work from the University of Michigan. He's a licensed clinical social worker, and started meeting with Single Payer San Joaquin group in 2007 or 8, and was the chairman of that group for 2 years. Was during the early years had gotten Representative McNerney to co-sponsor HR 676. Worked with the group to get him to co-sponsor that, and that means that Jerry McNerney may be open to future overtures on single payer health, and so he's working now with this group to try to get single payer enacted in California, and so that's what we're going to be talking about this evening, and just sort of also what's going on with single payer right now, and how we can move forward in the future. So welcome.
Thank you.
Thank you very much. So what is going on so right now, single payer may seem like it's in a work in progress stage. I mean, are we? Where are we farther along? Were you farther along at the state level, or are we farther along in the federal level, or are we still just sort of educating ourselves as to what we should be doing?
Well, I think the important thing is that we're educating the public as to what single payer is. Our local group is focused on the state. Nationally, there's the movement to Medicare for all,
right,
which would be fine,
right.
But that seems to me is a longer goal than even single payer in California.
Considering that Republicans control both the Senate and the House of Representatives and the White House, and are pretty much opposed to a for lack of a better term, a socialized medical system. Now, so when people talk about Medicare for all, is that when we're talking about socialized medicine, which is sort of, just throw that out there because a lot of people have a problem with that idea. Is there a difference between a socialized medicine model and a Medicare for all model, or what?
Well, yes. a socialized medicine, generally the term is used to describe healthcare like they have in England, where the government owns most of the hospitals and clinics, and the physicians and treating personnel are employees of the government.
Okay.
That's socialized.
And they've had that since like World War II, the end of World War II.
Yes, correct. Single payer is a way of paying for independent treatment, independent physicians like Medicare. It is a social thing, like the street I drove on getting here is a socialized system.
Right.
But that's the only way that you can have adequate medical care at any kind of reasonable cost. We have terrible health care in the United States.
Right.
Our survival rate is 3 to 5 years less than any of the other industrialized countries.
You don't hear those statistics quoted very much when people talk about how great our system is.
I don't. It used to be every time that I would go to talk about single payers, somebody would say, "But we have the best health care in the world," and my hair would catch on fire because we absolutely do not have the best healthcare system in the world. We have one of the worst healthcare systems in the world.
Now, when you talk about healthcare systems, you're not necessarily talking about the doctors and nurses and hospitals that provide care. It's the system that's a
exactly
concern.
Yeah. There are some statistics that like the the infant mortality rate.
Indeed, right.
Is greater than the United States than any other similar country.
And when you talk about like minorities, African American women and children, it's even worse.
Right, but it isn't just the minorities. It may be worse in some minority situations, but the care generally is the worst. Now, for some wealthy people, we have like a dual system. We have health care for the wealthy,
right,
and then we have what everybody else gets.
Yeah.
And the wealthy do better, but it still is not adequate to what is available in other countries.
So what we're talking about is a socialized medicine system would be highly disruptive in the United States and would be very different than where Britain picked up like 60 years ago, but here, or 70 years ago, I guess. But here what we're talking about is adapting our existing system to a different way for paying for cost. But anyway, before you respond to that, I want to introduce a fourth member here who's joined us, Susie Arnett, who is a retired physical therapist and has worked very diligently on the California Disclose Act, which is something that we will be getting into today because we're talking about healthcare. We're talking about when we talk about healthcare, we're talking about money that affects large corporate interests and large financial interests, and the Disclose Act was designed to show people where the money goes to buy our legislator. I mean, to fund our legislators. But of course, you don't have to buy votes in the legislature. All you have to do is buy a candidate, and that's the problem with the Disclose Act. I mean, that's a problem with not having a Disclose Act, is
Correct.
that people don't know who has purchased their legislators. So anyway, welcome, Susie.
Thank you.
Very nice. And so, Kathy, we were talking about the single payer system. As a physician, you would think that maybe physicians wouldn't be too thrilled about a single payer system. Why would a physician want to sign on to a single payer system?
To eliminate all the hassles of figuring out who is in the network and out of the network, and to definitely decrease the paperwork and the time it takes to get approval for things like procedures.
Right.
Yeah.
Right, in terms of having to find a pharmacy that will accept this insurance, or a lab that will accept that insurance, and then having to send your patient someplace that's far away, whereas the lab is right across the way, and they can't use that one because their insurance won't.
Yeah, the question of insurance networks, I think a lot of patients are a little bit less aware of, but when you make an appointment to see the doctor, really the first question you get when you call is, well, what's your insurance?
Yes.
And if you can clear that hurdle, you can get an appointment maybe, but when you show up for your appointed time, at least in my practice's office, that really just sets the clock going so that a couple of phone calls can be made to make sure that the visit will be covered. So you may not be seen for at least a half an hour, or called back for your to be taken to the exam room.
Oh.
Yeah.
So
I mean, it starts there, and and then if your doctor wants to, provide something for you, give you some kind of a device or a procedure, you can schedule that for some time in the near future. But in the meantime, a bunch of phone calls will be made to your insurance company to see if they're going to cover that or not. And they may or they may not, there's always, and then if they deny it, then you got to do some kind of, you might be able to put together some more documentation and ask for an appeal.
Yeah,
it just goes on and on and on.
I never, well, I guess I should have. I never really thought that the insurance system is the thing that causes the delays at a doctor's office, because when folks go to a veterinarian, it seems like you can get things done like on the same day, and you don't have, because insurance is so rare in veterinary medicine.
Yeah,
and
the
so
conversation is, do you want to put this on your credit card?
Yeah, that's about it. And then, okay, let's do it now because it has to be done now.
Yeah.
The issue is that it costs the doctor about 20% of their income to do all that.
To pay staff to make those phone
Right.
calls,
Yeah,
yes,
right.
and the faxes and yeah.
Yeah, I remember working at MAC Health Board. I mean, there was a huge billing department, and there was the whole deal about.
Billing
I mean, there's
departments.
I mean, they're coders, and they're very adept at trying to make sense of charts, I guess, that the doctors write up in terms of what are we going to bill this person? What sort of procedure was this? Was this an extended office visit, or was it a super extended office visit, or was it, did they? And now
can we possibly upcode this?
Yeah,
Yes.
exactly,
Yes.
right, and that's what from my perspective as on the financial side, it was like there was like this pressure to upcode, and well, we were a nonprofit, so the thing is that. Where I worked was a nonprofit that worked with the tribal communities up in the foothills, and so we did. We were a billing shop, but also got some subsidy from the BIA to take care of the tribal folks in the hills.
Then there's the follow-up.
Yeah. Well. Yeah.
If you don't get paid,
Yeah.
if it was billed and everything looks good, but they just don't pay, then there's someone in the office that figures that out and has to call the insurance company, which usually results in being on hold, interminable.
Oh yeah.
And then there's
a lot of
billing,
people are
you know,
paid
and
a
then-
long time to
and-
sit on hold. Yes.
Yeah, and then there's the billing of it, and then the thing is I was saying about the billing department is that there was, you go to trainings, and there was this trainings on how to train coders to get physicians to upcode things so that they can say, well, didn't you just take an extra moment to look at that person's elbow or something? Well, then we can throw another $50 on top of it for that, and it's like there's this constant pressure to increase cost, I guess, to cover this 20% you're talking about. That would be, that you're trying to that you have to cover in order to wade through this morass of of billing.
I'm not
and
sure if
codes.
that even begins
Well,
to cover.
because your healthcare dollar, as you know, as from the point of view of the patient or the consumer, as they like to refer to us patients,
Sure.
you know, probably about 30% goes toward that kind of bureaucracy. A good 20%, 15 to 20, is on the insurance company end. They've got, you know, floors and floors of people in cubicles who are doing nothing but looking at medical notes and looking at requests and basically denying anything they possibly
Right.
can.
Sure.
And then on the medical office side, you have huge billing departments in every medical office, in every medical practice, and there are large companies that just employ medical billing people that smaller medical offices can hire, you know,
Right.
to take care of that. But
Right.
it's all got to be covered
Right.
by the insurance company dollar that's coming in,
Right.
plus the co-pays and the deductibles paid by the patient. But pretty much out of every dollar that's spent on healthcare here in the United States, 20 to 30% is covering those quote-unquote administrative costs. In a single-payer system, say you had an office that only took Medicare patients, Medicare runs at an administrative cost of 2 to 3%, not
Right.
20 to
Right.
30.
Right.
And so, you know, in Canada, where they bill in a single payer way, all the bills are going, they do the codes the same. I mean,
Right.
these billing codes that we have are international.
Right.
And in a fee-for-service system, which most countries go by, even when you're using global coverage for, say, a clinic or a hospital, you still need to account for everything in a fee-for-service way with codes.
Right.
It's all going to one place,
Right.
and it's all getting paid a lot more easily in terms of everybody's in-network. And usually there's a little bit of trust or understanding with the doctors, and there's not a whole lot of haggling that doctors have to do to get, you know, approval to do procedures or place devices. I'm referring to in my field of OBGYN. You know, you don't have to call an insurance company and set up a separate visit to place an IUD, for example. Patient wants one, you got them on the shelf.
Yeah.
You know, you set up the appointment maybe for later in the day, but
Right.
you can do it that same
Right.
day. It's not a big deal. It doesn't involve a bunch of paperwork and phone calls and waiting on hold to get approval to do it.
So Susie, what's your experience? I mean, you're as a physical therapist, right? Did you
Right.
ever have experience dealing with insurance companies and having to deal with paperwork and
Oh, constantly.
Yeah. So did you work in a hospital setting or on a private practice setting or what?
I sort of worked in a lot of them, but the last about 10, 15 years I worked in home health.
Okay.
There's a tremendous amount of paperwork. In fact, the paperwork that I would have to do would generally take almost as long as the patient care.
Yeah.
It's literally what caused me to retire at 65.
Wow.
Because the paperwork was just taking so long. It was just, it's oppressive. And to try to find, for someone who's been sent home from the hospital, but they've had a stroke and they need a brace on the leg, if that hasn't been addressed then, it just takes a long, long time to get the brace. And here they are, now they're home, they're walking, they're a huge risk for falling if they don't have this brace. And it takes a long time to get it made. If it was taken care of quickly, the quality of life is just so much better. It's really sad that so much of our healthcare dollars go to non-healthcare things like paperwork, like justification for this AFO, we call it, which is a short leg brace for a patient that's had a stroke. In almost every single case, certainly in home health, there's like 35-page report you have to do every time you open a case and then close. And I forget how many questions it is, but 35 pages worth of questions, it's a lot.
Yeah. Well, this is Peace and Justice Connections. We're talking about single-payer health with Max, Kathy, and Susie. And we're talking about the current status of our health system. And why it probably should be scrapped and replaced.
Yes.
You know, I was struck by, you know, when President Obama was negotiating the Affordable Care Act back in 2008 or 2009, 2010. And felt like, you know, and the first thing that was off the table was single payer. We can't have single payer because, you know, of course, if we were starting from scratch, that's where we would be. But we're not starting from scratch. We have the system now, and so we have to work with the existing system. What's wrong with that? What's wrong with that argument?
Well, it doesn't work.
Well, and because it's not the system of offices and hospitals, it's the problem. It's the payment system. And it would be very easy in an apolitical world, or a world that just wanted to operate in an efficient way, to say there's no reason to have insurance companies. They don't provide health care. Let's just have, you know, this administrative group in the Medicare system that pays the bills that are submitted by healthcare providers. We don't need insurance companies to decide who can and who can't get health care. They don't otherwise provide anything of value in the system.
Well, now at some point there will be some gatekeepers who have to decide. I mean, in a limited resources system, there will have to be some decision as to what sort of care is more important.
I think it's way minimal. I was just going to ask Susie about these 35 pages. In any way, shape, or form, one would hope that they would end up, I mean, that's a lot of paper, you know, just...
Yes.
Do they in
It used to take me 2 hours just for that, not even before you even really discussed the deficit
in any
at
way
hand.
did they direct you to provide better care or give you any roadmap to what would be better care?
I must say it did. It tracked pressure sores. It tracked whether you had them at the beginning of care or not. And they do this actually in the hospital as well. So now if you do not have a pressure sore when you come in, if you have one while you get there, they don't pay for it. So it has really made the hospitals be much more careful about pressure sores. Mm-hmm. It does track things like urinary tract infections with catheters, things like that. There is some advantage to it. It's a tremendous amount of data, but it doesn't have to be that onerous.
Well, and Medicare does implement those things. Those are best practices that actually most Medicare providing institutions are following, and if the pressure is coming from Medicare, they're leading it. The for-profit health insurance companies are really kind of going along with it. They agree, and they're happy. They're happy to do that. But those kind of quality measures are absolutely obtainable, and in fact more efficient in a single-payer system. I mean, if you don't mind, I'll just sort of segue into the topic of electronic health records, because it does kind of play into this. There was an electronic health record system called Vista that was developed for the Veterans Hospital System back in the mid-aughts, and doctors are very happy with it, and it's throughout the Veterans Hospital System. You may or may not know that in recent months, after President Trump came to power, Jared Kushner was put in charge of, I don't know what, but something having to do with the VA. But he pretty much farmed out the electronic record system of the VA that was working perfectly well and was actually kind of a model in this. He sold it out to a big provider called Cerner, which also is in, I don't know, a huge percentage of the hospitals now. And the problem with these other electronic medical record systems, and there's a whole cafeteria of them thanks to Barack Obama, who didn't want to offend the electronic medical record provider market. They're not designed for efficient use by doctors and patients. They're designed for computer companies to make a lot of money, and and insurance companies to make a lot of money.
Yeah, because there's this large amount of money. I mean, everybody needs health care. Everybody, they don't want to skimp on health care, especially when you're the more and more endangered and more sick you are, the more important it is for you to have good health care. And so people don't want to skimp on health care. And so the thing is, the organizations that see that opportunity say, well, this is a wonderful profit-making model, because you have people who would say, money is no object to save my loved one. And so so they're willing to throw money at something, and insurance companies or corporations or medical device companies or drug companies are more than happy to sell above whatever a market would provide.
Right. That's the problem with our whole system. It's made to provide profits for not so much for the doctors, certainly not for the patients. It's made to provide profits for the insurance companies and medical device companies. It is not meant to provide good health care.
Right.
That's
the problem.
sort of a secondary consideration.
Right. So do people know?
You almost get better in spite of the system, which is really sad.
So when we're talking about the system, when we're talking about making change at a governmental level, what is keeping us from making that happen on a legislative basis? I know you worked on the Disclose Act, and so
what is keeping us from it is a lot of the insurance companies who have lots and lots of money can have lots and lots of lobbyists, and without that money, without the profit motive, none of this would be going on.
There are any number of legislators who, before they were elected, were in favor of the single-payer model. Obama, most notably, as a senator, was in favor of single payer. But when he now is elected and he's worried about
he has the Senate and he has the House, and the Democrats are controlling all levers of power, as Trump is now.
And the power brokers immediately were on him. In the first week that he was in the White House, Pharma was in the White House with him.
The lobbying group for the pharmaceutical companies.
And that's when they came up with the current law, which makes it illegal to buy cheaper medicine from another country.
Right.
I mean, they don't prosecute individuals, I don't think, for doing that.
I haven't heard them do it, but it's not legal. But
it's not legal for individuals to buy their medicine in Canada.
So as part of the whole Affordable Care Act, as it's called, that was adopted in 2010 after a very long procedure and a very long discussion and a lot of compromise with Republicans in the House and the Senate. The result that we got out of it really wasn't a whole lot closer to a single payer. Well,
there were a few aspects to the Affordable Care Act, which is a flaw of it, but that it wasn't it didn't fix the whole thing at once. It absolutely kept the insurance companies in the game.
Yes.
It did ostensibly deem that they could only make 15% of every healthcare dollar, and they've seemed to find a workaround on that.
Yeah, it depends on how you define administration, and I work in that realm, and it's very you can define certain things that are admin. You can call them program aspects if you.
So that's another way of them to make some more money.
Exactly.
But the aspect of the Affordable Care Act that I think most of us would approve of is that it expanded the amount of money that people can make and still qualify for Medicaid. Used to be if you made a certain percentage of over the poverty line, you couldn't qualify for Medicaid anymore, and it allowed a good 30 million more people to get Medicaid than who had.
Who didn't have children.
Yeah, that's one of them. Single men, for one thing.
Right. Yeah. So Medicaid is we call that Medi-Cal here.
Yes.
And Medicaid is different from Medicare in what
so
way?
Medicare is for people over the age of 65, and
or disabled.
And there's a few aspects of Medicare. hospitalization is covered 100%, but office visits are not. And so when you see the ads for Medicare Advantage plans, basically those are, wait a minute, let's back up. Supplemental insurance, sorry.
Right.
Supplemental insurance to Medicare is to cover the 20% that's not of office visits that's not covered
So
under
everybody
Medicare.
has to have that sort of coverage.
Yeah, or when you get older, if you start going to the doctor a lot and just going to office visits, you'll find out how much a copay and a deductible will cost you.
So even if people
don't-
are on Medicare now, they
You don't
are,
have to have it, but 20% of a large bill can be quite a bit of money.
Right.
Yeah,
Right.
yeah.
If you have to have open
Well,
heart
that-
surgery, 20% is a big chunk of
Well,
change.
but as far as I know, the hospitalization aspect of it is covered. It's once you're going to the doctor
Right.
frequently. If you're going to the doctor every 2 weeks or
Right.
whatever, those $20 copays and the billing according to the coding of that doctor on that visit, that 20% can rack up pretty fast.
So when we're talking about Medicare for all, we're still talking about, if everybody had Medicare, like say what I've seen some plans being, like the Bernie Sanders plan is being like, that every year the eligibility age would go down by 5 years. So now it's 65. The next year would go down to 60. The next year would go down to 55. The next year would go down to 50.
He would phase it in
It
for
would be
every
phased
age
in.
within about 10 years or something.
Right.
But still, Medicare for all isn't a single payer system because there's these supplemental insurance plans that you have to take if you want to be fully covered.
It would be if you had what we call National Improved Medicare for All.
Right.
The Improved
Right.
Medicare for All means 100% coverage.
Okay.
Yeah.
Is that what they call Medicare
Which is
Plus?
we're just advocating
Okay.
a single payer.
Single payer,
Not
not just Medicare for all.
So when our opponents
Yes.
of a certain political persuasion like to attack us, sometimes they'll say, well, Medicare doesn't cover everything anyway. Well, if we were to rewrite this law and reset up the medical payment system, it would.
Okay. So then the Medicare
It's an
a plus or
improved
whatever
medical.
the extra Medicare supplement with a Medicare for all program, there wouldn't be a Medicare
There wouldn't be
supplement.
any
It would just be
supplements.
all one.
It would all be
one-
100%
and
coverage.
the drug would be, I
Yes.
guess, depending on the program, the drugs would be wrapped into that.
Yes.
Right.
If you remember when George Bush was running, he said he was going to cover
Right.
medicines and drugs. And finally, in the second term, he came up with this plan which forced people to get Medicare D if they wanted their drugs covered.
Right.
Which was part of some of these supplemental programs.
Right.
So your supplemental program may or may not cover medication. And
So Medicare D is an additional.
A National Improved Medical Care for All, which is our ultimate dream, would be 100% coverage for all medical, dental, physical therapy, optical, and then other devices, your glasses,
Vision.
your hearing aids.
Right.
drug treatment, psychiatric
Yeah,
treatment.
and
Right,
your
yeah. Mental health
medications.
care.
I mean, yeah.
So all these parts, what we've been discussing are a mind-numbing array of parts. Medicare D, Medicare supplement, 20% is covered. All of that, if we're talking about a single payer system, all of that would be swept into a single payer, a
single risk pool.
A
Yeah.
single
Right.
risk pool. Everybody from young to old would be in the same boat.
Yes.
Correct.
And so the costs would be shared or spread amongst everyone.
Everyone.
Because sooner or later,
Everybody's gonna
a
need it.
16-year-old
Right.
is going to become an 80-year-old.
Yeah.
And so at some point, you're going to need this care.
Yes.
Right.
At SB 562 would cover all
Now, that's
the
a state
single
bill.
payer
It's a state,
program.
That's a
California
state
state
And
bill.
the people you're talking to here today are we're in favor of that because that seems to be perhaps the thing that California could do to get to this Medicare for all, whatever you're going to want to call it. Whereas nationally, I can hardly, seeing how hard it is in California, where we have things set up to move to it in a way, but nationally, you have like entire states against it.
Well, you have
Is
entire
it-
states that didn't sign up for the
Right.
the Medicare, the
Medicaid
enhanced, the Medicaid
expansion.
expansion.
Yeah.
So anyway, back to the Medicaid.
Yes.
So now that's another portion of our medical system. Now, how again?
So
back to that, how is
Medicaid-
that different from Medicare?
Medicaid is a program for poor people.
Okay.
So so where you put the income limit to qualify as being poor, that's an important provision. That's an important designation. There are some people, if they get a certain job making a certain amount of money over whatever they made last week, all of a sudden they lose their Medicaid. So they don't want to make more money.
I see. So because
they don't want to take extra hours.
So what does
or,
Medicaid cover?
Medicaid covers one thing it doesn't cover is dental.
Okay.
But its reimbursements are lower than Medicare's, and so that's the problem for a lot of people who have Medicaid. They can't find providers who accept Medicaid. But there are a lot of clinics called federally qualified clinics, and you may understand this a little better than I do, Bruce. But they tend to be nonprofit. They tend to be run by the government, and they do accept Medicaid. In fact, they may only accept Medicaid.
In fact, when I worked at MAC, what we did was we had a formulary that was. That when I was there, we decided just to use the Medicaid formulary. Before that, we had something that was because we were billing insurance companies, we would be able to bill something higher than Medicaid. But since we were working with generally low-income population, and since frankly the clinic was all of the clinics were making money substantially, it still made financial sense for us to use the Medicaid formulary. But
so let me just clarify for listeners who may not know that term, because I know
sorry.
I didn't before I went to medical school.
Yes.
A formulary, as I understand it, is a list of drugs that are covered under an insurance
and also
program.
what we were call, and I would call it a list of procedures as well.
Okay.
So it was
things that are covered.
At
but
that clinic. In a clinic, not in a hospital, but in a clinic. So it's sort of like outpatient type, or it's still inpatient stuff, but like incisions or maybe even a broken bone or something, but nothing that would be like that would hospitalize you. And so none of the doctors made more than I think $250,000, which to me is not bad. But and it was a nonprofit agency, and it was the most successful nonprofit I've ever worked for. It did not have any financial problems, and there were no foreseeable financial problems because there was just there was these
demand.
There's demand, and the expenses were reasonable, and and the formulary charged enough.
I mean, tell me, did you have trouble getting money from the government when you submitted your billing codes? Did they haggle? Did they disagree with the need for these things, or did they generally say, "Yeah, the doctor wanted to do such and such and so, here's your check"?
Well, I didn't. It was fine. There wasn't a whole lot of because when you're dealing with Medicaid level billings, I mean that's sort of what the government
supposed to do. Right?
Well, because my understanding, I'm not on the financial side. I'm really just an employee of a private practice.
Sure.
But my understanding from hearing from people who do run their own private practices and they're on the business end of it, is Medicare is one of the least difficult payers to get money from.
Yes.
Yeah. And then
and Medicaid too.
And Medicaid as well. And so the thing is that you would think that if there's a lot of money to be saved, there would be some pushback from folks who are currently working in the system because once a single payer system is adopted, there would seem to be a lot of extra coding people and a lot of extra billing people who would have to find jobs somewhere else.
They will. And that guy who's the head of Blue Shield who took home, $200 million in a bonus a year or two ago, he's going to have to find another source of income as well.
Right.
And I feel bad about that, but
we all should.
When we switched from horses to cars, we didn't, really fret heavily about the horseshoe makers.
About the buggy whip people.
Yeah. Right. I mean, they had to retrain.
Yeah, that's right.
Well,
and then these are bright people. I mean, the thing is that people who are doing this coding and this working on medical billing, I mean, that's not That's not easy stuff. It's very frustrating and very complicated.
And they are going to be familiar with medical terminology and medical procedure.
Right.
And if we have single payer or Medicare for all, or whatever it is, we're going to need more people providing service. So some of them are going to be well qualified to actually provide meaningful work.
Instead of just providing profits, they'll
instead of putting the other person on hold and making them wait while they do whatever.
And actually, they don't provide profit. They just provide income for insurance companies.
Correct.
Right.
So they would be able to do meaningful work.
Right.
And
to expand care.
Yeah, SB Senate Bill 562 has built into it some retraining. Funds.
And we can do that.
Yes, absolutely.
When we pass our national single-payer bill, we'll retrain those folks.
It may come sooner than we think because a lot of people are really frustrated with the current system. This is Peace and Justice Connections. I'm here with Max Heineman, Kathy Mathis, and Susie Arnett. We're talking about single-payer health care and what our prospects are coming up here. This is 2018 now, and I think we've been talking about single payer since I don't know, maybe the Nixon administration, which was a lot of.
The Nixon administration was the administration that allowed Humana to be no longer a nonprofit. He allowed Humana to now have profit-based hospitals. That's where this all started.
Well,
we didn't used to have this, which is why we had
Blue Shield,
the
Blue
best
Cross.
medical care in the world. And then slowly but surely, the profit margin, eats into everything. And when you have a for-profit system and the profits are enormous, this is what you end up with. This is, the medical care now is sort of incidental.
To the profits made by the hospitals, the insurance companies, and the
to think of
pharmaceutical
all the
agencies.
money that is made, if it actually went to good medical care, can you imagine how healthy we would be? Right. And even the stress of the physicians. You actually get to practice medical care like you thought you were going to when you went through medical school, instead of dealing with insurance companies and having to justify everything you're doing. I think it's a huge burden on the physicians. It's an enormous burden everywhere to have a system that's supposed to be for medical care, but it isn't really. It's so deceitful.
Right. And it would seem to be the way that the Bernie Sanders group is going about doing, I don't know, the SB 562 group in the state, would be in terms of transitioning from this system. I guess it could be like sort of a Bear Stearns Lehman Brothers type of thing, where they allow these or they cause these companies to go bankrupt or just to have them go out of business. But it seems that the process of sort of slowly weaning or slowly moving towards a Medicare for all system by either every year going back 5 years. I think that's pretty quick. I would say, like, if every year you decrease you move the eligibility rate maybe 3 years or something, so that over time health insurance companies could find other work. Well,
but there's a lot of suffering, Bruce. I mean, really, from the point of view of those of us who are activists, it's not moving quickly enough. We should just convert tomorrow.
I see.
Right.
Because and when you talk about suffering, you're talking about people who are
going
decisions.
without medical care.
Right.
People are going without
who are dying because
medicine.
they don't get the medical care that they need.
Right.
And if you remember, when the economy went in the toilet 8 years ago, or however long ago it was, there was no problem letting Lehman Brothers go, and bailing out the car manufacturers for what they wanted. That can be done, and we seem to have survived it very nicely.
Yeah. And people, I mean, it seems that patients just sort of suffer quietly and try to get by as best they can on an individual basis, because they don't see that it's a systemic problem.
There's a fabulous new book out right now called Teeth by author named Mary Otto. I don't remember what the subtitle is. It's something, the story of beauty and equality and something else, dental care in the U.S. or whatever. And it talks about how many people in our country are going without dental work. I mean, from the time they're children, and that toothaches are a fact of life for a very large percentage of our population. And then when poor dentition leads to loss of teeth, some people are so socially marginalized by that, and their diets suffer and their health suffer because of that. And yet it's not even acknowledged as part of our medical system at all.
Dental and vision are just like add-ons.
And that you guys may or may not remember the death of a young man, of a boy named Diamante Driver in 2007. It was actually a bit of a sea change, and it was brought to the attention of a number of members of Congress, including at that time Donna Edwards, who was an African American representative from Maryland, and also Elijah Cummings, who still is in the House. Donna Edwards mentioned that she lost a brother to an infected abscess tooth that went into his sinuses. He was only 26. Elijah Cummings grew up very poor in Maryland, and he said toothaches were just part of his childhood. And anyone who's ever had a toothache, even for a day or two, knows that kind of pain completely takes over your world. And there's a little vignette in the book of this family, a young couple who are in their 20s, and the young man's mother, and they live in northern Florida, and they drive all night to get to a one of those county health fairs that is discussed by Wendell Potter in his book. It's like out at a county fairground, and they have dental chairs set. I believe we do. Dental chairs set up in cattle stalls, and they drive all night to get to this thing. And the young woman has this throbbing toothache that's going into her sinuses, and she waits in line, and she finally gets to the head of the line at like 5 o'clock, and they tell her, well, we'll see you tomorrow, and you'll be the first one. And yet, she's actually terrified. The whole time she's sitting there with her face, throbbing like it has for months at this point. She's still very afraid to sit in that chair, and she doesn't know if she's going to come back the next day. And they settle in for the night in their car, because that's what they have to sleep in, for another night of this, terrible throbbing pain. And you just imagine, as I was reading this vignette, I was imagining, millions of people who suffer silently at night with this individual pain, and how pain at night, when you're alone anyway and it's dark, is just so terrifying. And she, even though she was in a car with her husband and her mother-in-law, must have felt very alone and very frightened. And the only solution they really could offer her was an extraction. No implant, we're not going to make your smile pretty, and we have this, generation of young people who've lost their teeth from methamphetamine use, and now they're smoking heroin, and, they're losing their teeth from that, I'm sure. My opinion, when we get single payer, one of the things we ought to do is a full-on Marshall Plan for dental implants, and just say, everybody gets a new smile. And because it really is a life-changing thing. It brings people confidence and comfort, and they can go out and do things that they didn't think they could.
It's astounding what this country, the priorities this country has in terms of thinking of national security, or of what priorities we have. I mean, there was just a huge bill that was passed by the House and Senate and signed by Trump, that $1.3 trillion spending package, over half of which was for military spending.
Priorities.
Yes, our priorities.
The biggest spending, $60 billion, the biggest spending increase in military spending since since Ronald Reagan. That's what they were saying. $60 billion in 1 year, and now the
because the Pentagon was hurting.
Well, now the difficulty is going to be. I mean, this is a department that has not and cannot be audited, because they cannot keep track of where their money goes. This is the department that
they just lose trillions.
Well, they drop pallets of cash to Iraq to pay off people. And so and now the problem is, here we are in March, the fiscal year ends in September, and now they're going to have the biggest problem is, how are they going to spend $60 billion additional money before the end of the fiscal year? 6 months. And so every month they're going to have to spend $10 billion, $10,000 million. Gee, how can you... It's
$10,000 bills.
It is just
absolutely ludicrous.
It's just amazingly ludicrous what passes for what is acceptable, what is possible in this political climate. I just can't believe that people understand this. And if they did
they
understand
don't. They've become so disheartened. That's why there's so many people that are apathetic, because it's not just because they just don't care anymore. It's because the system begs them not to be cared.
They think nobody cares about them.
Exactly, and that is the way it is.
And this is a huge country, and we tend to think of the way it is here. We're so nationalistic that it must be the best way, and the fact is that we're not doing it the best way.
Right. No.
And but people don't want to admit that to themselves, and they don't ask for things that are better.
Right. Yeah, I mean, you look at countries like France or any one of the European countries that has a more, that they're more frugal. They have a better idea as to how to pay the medical establishment in a way that doesn't extract tons of profits out of people. And I'm just reminded of the movie Sicko, which was very. There were some parts there that were just just heartbreaking in terms of seeing how people were served in some countries and how they just aren't served here.
Yes.
Right.
You know, the distinct, and this country is woefully ignorant.
Kind of one of the things that we don't understand in terms of medical care in the United States versus these European countries. In the European countries, the government has enough control over healthcare services that they can change quickly. They can make changes if a painkiller epidemic arises. They're going to have they can quickly change how they deal with that. In the United States, we jump on the primary care physician, and he jerks people off of pain medicine that have been on it for years. They may or may not be physically addicted, but suddenly next week they're not going to get a prescription for their Vicodin, or whatever.
That's our way of dealing with the opioid epidemic.
Yeah, right.
Is
That's
to
right.
Make another problem.
Threaten the primary care docs.
Yes,
that's right.
Exactly.
Well, yeah, and that's exactly what's happening. I don't know what
problem solved.
Right. And I don't know. I always think that with every administration, it's a teachable moment. But the thing is that people have to be primed for learning. I mean, I think people have to be willing to, like you're saying, people are just so beaten down that they don't expect anything anymore.
And we used to be a country that were problem solvers. Mm-hmm. When you have a problem, what's the best solution? What has someone tried? What has another country tried? Let's learn from that. Now it's like, who's going to make the most money off of it? How are you going to get around all the lobbyists? It's got nothing to do with common sense and rationality. Yeah. It's as far as if you have a problem, well, it used to be, okay, everybody get together, let's figure out how we're going to solve this problem. Now the attitude is, I've got mine, you're on your own. Nobody wants to help, and then even when you have a system, nobody seems to want to, it's somewhere we have forgotten that you look at a problem, try to find the best solution, and let's go with that. It has too much to do with the monetary.
Samples that are working better.
What works best, yes. Yeah. Let's try 5 of the things that work best. You choose or just decide on one of them. Try it. If it doesn't work, let's try something else.
Well, this is an election year. And so it's when you listen to people who are in elective office, they come off as being so polished and so slick and so I don't know, commercial. You know,
Yes.
It's difficult to think that, you know, that they would do anything that would be against your interest. But, you know, because when they're running and they're in elective office, I mean, Kathy, you know, you're a politician. And you are so smooth and polished, and so and I'm an aspiring politician.
Absolutely.
But
I contributed to your campaign.
that's right. But you know, it is a time to really look at our candidates and to really ask the hard questions and
Yes.
ask them what do they think about a single payer system. I mean, there are this last March for Our Lives this last weekend that young people were saying that this is the issue that they are going to make that they will vote on. Single payer system is, I would say, as important because it is as much of a life and death
It is.
issue.
It's as important.
as a gun to your head. Because if
Yes.
you can't get medical care, you're dead.
Exactly.
You know?
Exactly.
Well, I see it that way. I'm not sure
Yeah.
a lot of the politicians do. What you're going to hear from a lot of politicians who are under some pressure to address this issue is they're going to say that they like the idea of a public option. That's sort of the Democratic Party's way of working around this.
I see.
They would really love for the problem to go away.
Well, me being 60 years old, I would love a public option because I am at the highest rate level that there is, and
Yes.
so my copay, maybe not my copays, but the premiums that my company pays on behalf of my family, and I said this before in previous programs, is that it costs $30,000 to pay insurance companies to cover me, my wife, and my 2 children who are 23 years old.
Well, my guess is, Bruce, and I'm
$30,000.
not the lawmaker on this, but
Yeah.
my guess is they're not going to give you the option of going away from your employer-provided health care
Well, that's why we
program.
need single payer.
Exactly,
That's right.
and
Exactly.
so do we.
Yes.
But I mean, let me get back to
Yeah.
the problem with the public option, because you're going to hear it, and
Yeah.
in fact, I think there's going to be an initiative on the next California ballot that will offer that, and what it's going to be is a Medicaid or Medi-Cal here in this state buy-in for people of a certain income level. But and I don't know the details of it, so don't hold me to this. But my guess, from the way insurance companies make their money and their influence over the legislature here in California, is that they're not going to let those employer-provided policies go away. They're not going to give you the option of going out and taking the money that your company pays for you to have insurance and get a better plan that doesn't involve a profit for somebody. They're just going to say, yeah, people who now can't qualify for Medi-Cal and don't have any other place to go, some of those people can somehow purchase a policy called the public option.
And they'll still go
I mean,
through.
it's a way of filling in the gaps a little bit more. So
Right.
instead of having 30 million people in the United States without health care at all, and I don't know what the number is in California, but there's some significant number. It's
Right.
getting health care to a few more of them. So we
Taking
can
the
kind
pressure off the insurance companies.
so we can incrementally
Allow-
move to a place where we have universal health care coverage. But the best way to do it would just simply be to end
Covering
insurance
people.
companies at all and just have one single pool.
So we
Think
have
of
to
all the
continue
people who have insurance. If you get cancer, what happens? Can you work through your cancer treatment? If you can't, and so you can no longer work, now you no longer have insurance.
Yeah, right.
That could
Yeah,
be a
that's
death
a big
sentence,
fear.
and
It's
many
like-
times
Oh,
is.
yeah. Yes.
Yes.
Yeah.
Yeah.
Even for those of us who have jobs and have quote unquote insurance, we live with the fear of losing our insurance.
Right.
That's right.
Yes.
And you're tied to that job then.
Exactly.
You can't retire.
change.
You
Right.
can't get a different job.
Yeah. So you're trapped.
Right. Right.
Right. Yeah. This was the initiative you're talking about was the one that I think SEIU came and pitched at our board meeting a couple couple months ago. I don't know if you were.
Yeah, I don't think I was at that meeting,
Yeah.
but
You would have
that's
had
the one
some
I'm
good questions.
referring to.
You would have had some good questions
Yes.
because that was the board was resistant to that, be saying, isn't this shortchanging a single payer system? Shouldn't we be going straight to a single payer system?
Well, and how
rather
does
than
this
taking
remove
detour?
all the complexity of a multi-payer system that
Right.
involves all that bureaucracy and all that waiting on
Doesn't
and
just
the
add
limited
one more piece.
provider networks
And all
yeah.
of the money that's siphoned off to the
Because
insurance.
of that.
Right,
Yes.
exactly. And we even have other health insurance programs. The insurance program if you are injured on the job. That's a whole nother system. We have so many systems. It's redundant.
Yeah.
Plus, it makes it so complicated. If we had one single payer system, it would streamline the situation so much more. It would have better care. The money would be going to health care rather than paperwork and all these redundant systems.
Yeah, if you want to get Max going, talk to him about workers' compensation.
Very good.
Yeah.
Well, we'll have to leave that for another evening because we pretty much used up our hour here. So anyway, thank you very much, Susie, Kathy, and Max. It's been a wonderful discussion on Peace and Justice Connections, talking about single payer. Good night. Thank you very much.